A very good morning to ladies and gentlemen, and you are joining with a session of Continuing Professional Development, collaboratively organized by the Government Medical Officers Association, Society for Health Research and Innovation, and Sri Lanka College of Internal Medicine. Prior to introduction of today's topic, I would like to highlight the ground rules of housekeeping on this webinar. Please note that your access to video broadcasting has been terminated for an uninterrupted session, and you're required to keep your audio muted at all times. Any questions which need to be discussed at the end of the session could be posted in the chat box. The webinar link will be available from 9 a.m. to 9:45 a.m. 10 thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points. And the CPD points are strictly adhered to the national guidelines of the National Committee of Continual Professional Development. This is to improve and maintain the standards of CPD programs conducted by SHRI and GMOA. And thanking in advance for the strict adherence to the CPD regulations and your kind compliance, I would like to introduce the guest speaker today. The guest speaker joining with us today is Dr. Brammah R. Thangarajah, MD, MRCP, ESE, NAF. Dr. Brammah Thangarajah completed his undergraduate studies at Moscow Medical Academy, Russia, and completed his MD in medicine from the Postgraduate Institute of Medicine, University of Colombo. During his MD, he has been trained in nephrology at the Royal Infirmary of Edinburgh of Scotland Deanery and the Nottingham University Hospital of East Midlands Deanery of the United Kingdom. He has also been a member of National Training Program during his training in the United Kingdom. He completed MRCP London in 2013 and the European Specialty Examination in Nephrology in 2018. Dr. Thangarajah completed his further training in the subspecialty of nephrology at the National Hospital of Kandy and is a senior lecturer in the Department of Medicine, Faculty of Medicine, University of Jaffna. Dr. Brammah R. Thangarajah, who is a consultant nephrologist in the professional unit of the Teaching Hospital Jaffna, is joining with us today on the CPD session on overview of glomerulonephritis. Over to you, sir.
Thank you. Thank you very much. I do feel like I'm in possibly a voice audition. Probably I may have to start singing if things are not going well the way I expect things to be. Yep, I hope that you all can hear me clearly and you all can see the slides.
Yes, sir, we can.
Please, just give me a minute. No, I'll control it, please. I'll control it, please. I'll control it, yes. Yeah, it's the topic that we're going to discuss today, the overview of glomerulonephritis. My question for you all is, at the beginning, is it a good term, glomerulonephritis, or are we going to say it as it's a glomerular disease? For me, glomerulonephritis or glomerular disease is like an economy. It's quite difficult to understand. Everyone talks about it, but no one really understands it. In an economy, you get inflation. In a glomerulonephritis, you get inflammation. Often the inflation is understated, or sometimes it's very obvious. Same thing happens in glomerulonephritis. The inflammation might be understated or might be very fulminant. You can see it with the cellular proliferation in a glomerulonephritis. But traditionally, we use the glomerulonephritis where we see very fulminant evidence of cellular inflammation in the glomerulus, that is in the light microscope, then we tend to call it glomerulonephritis. But glomerulonephritis and glomerular diseases are quite interchangeable. That's because inflammation is always there whenever the glomerulus is affected, especially so even in diabetes, especially so in proliferative and other forms of patterns of glomerulonephritis. This is the slide that I would like to focus bit during the lecture. This is the anatomical structure of the glomeruli, and to an extent, if we would understand the structure of this, and more or less, we would be able to understand what really happens. What you see in the center, I'll try to get my pointer across. If you see in the center, this is the capillary. And the capillary we'll have studied in undergraduate course, it's fenestrated. You get some gap in it. And because of the gaps, okay, it enables the filtration. Then you get, because it's a fenestrated endothelium, anatomically it's not structured well. Then it is supported by the basement membrane. And because of the looseness about it, it's externally supported by these podocytes and these finger-like projections. These finger-like projections, they form interdigitations. When you have a cross-section, this is the cross-section of a finger-like projection. So you get fenestrated, that is windows in the endothelium. Then you get a basement membrane, that is to support the endothelium. And this basement membrane is made up of basement membrane of the podocyte as well. Then all these together, that's what maintains the filtration barrier. In between the podocytes, you get the slit diaphragm, the gap in between, and that is quite maintained by the podocytes and the tightness of it. On top of it, in between this, you get the mesangial cells. They do communicate with the endothelium, and especially so with the epithelial or the podocytes, and they form a tight grip, and or they might loosen up depending on the need, and they might control the gap in between this. It's quite a simplified version of it. And here, that defines where the inflammation happens, would decide what is the type of injury, what is the glomerular pattern that we are going to see. So if you get this, say, it could be, the inflammation could be of very many things. So it could be maybe an antibody that is directed against our own antigen. Maybe you say there is a glomerular basement membrane, there is an antigen exposed in the glomerular basement membrane, and the antibodies are going to direct against that. You get a membranous nephropathy. And if it's directed against one of the non-collagenous A4 type of it, and it's associated with inflammation, then you might get anti-GBM disease. So there might be antigen that is already there in the glomerulus. It might be there in the endothelium. It might be there in the basement membrane. It might be there in the podocytes. And when they are activated typically by antibodies, then they will provoke an inflammatory response. So antigen can be intrinsic for the kidney, or it can be extrinsic. Extrinsic in the sense it can be in our own body, maybe a DNA particle, maybe a tumor particle. They come into the capillaries and they got seeded in either of the spaces, whether it can be internal to the basement membrane or it can be external to the basement membrane, and then it might attach to antibody and provoke a response. Or it could be the other way, where you could have antigen and antibodies forms immune complexes. They come here, they tend to deposit in between the capillary gaps or in between the fenestrated epithelium and the basement membrane. So that is the structure. So you can have an inflammatory response that can be provoked by intrinsic antigen, or it can be provoked by extrinsic antigen. Extrinsic antigen can be formed within the body itself, or it can be alien or an infection or infection particle that comes into the circulation and spreads there. And depending on where it gets deposited, where the infection or the inflammation happens, then you will get a clinical picture. Just imagine if you get an endocapillary, within the endocapillary region itself, you will get an active inflammation. You get endocapillary proliferation. You get active cells. You get macrophages. You get neutrophils. It's highly inflamed. Then what happens? It gets crowded. It gets edematous, and their function would tend to come down. So this is what happened in a very proliferative glomerulonephritis. You get inflammation within the capillary, and these inflammatory cells would try to disrupt the basement membrane. And because of the disruption of the basement membrane, what will happen? whatever the cells that are there in the capillary, they would tend to leak out into the Bowman space. So if you get an active inflammation, there is cellular proliferation, endothelial cells can proliferate, there can be inflammatory cells that's congested within the capillary wall. They will lyse the basement membrane. When the basement membrane is lysed, then the red cells, generally they cannot travel through, but they can seep through it. And this red cell, because they had to travel through the tubules for a longer period, they change their appearance and they become dysmorphic red cells. Or the seep red cells would go through the tubules, and then you get the Thomson-Horsfall protein, and they get impacted with them, and they form the cast in between. So you can have a first picture that is a proliferative glomerulonephritis kind of a picture, where the proliferation is well defined within the capillaries. And because of the capillaries are well inflamed, they are going to disrupt the basement membrane. Then they are going to seep the red cells, and then you'll get some dysmorphic red cells. This is what you get in an acute glomerulonephritis. The inflammation is there, there is red cells. Because there is edema, there is inflammation, the EGFR is going to come down. Because there is inflammation, there is no effective filtration. Fluid is going to retain. Because the fluid is going to retain, and you are going to get some blood pressure high, and you're going to get some fluid overload status. So what will happen in a glomerulonephritis? You get inflammation of it, you get dysfunction of it, and you get fluid retention of it. And because of the disruption of the basement membrane, you will get red cells that is seeping through the basement membrane. That would be seen in the urine as dysmorphic red cells, or at times as red cell cast. So when you get this picture, you are thinking, okay, the inflammation is happening within the endocapillary or in the capillary region. Just imagine the other way around. Nothing is over here. Everything is going to happen outside the basement membrane. It's going to happen in the podocyte. It's going to happen outside the membrane. So what will happen? There is no active inflammation as such. These podocytes, they maintain the strength between the gaps, and they maintain the slit diaphragm. So when the affection is more over here, maybe in an FSGS, maybe in the minimal change disease, the inflammation changes the structure of the podocytes. They cause effacement. The critical appearance, they say for is, the podocytes need to stand straight like soldiers and protect the basement membrane. If they're going to lie flat, and they lose their function, and you will get some proteinuria, and you get some nephrotic range protein. You will not get any red cells because the basement membrane is not affected. It is intact. There would be no significant cellular inflammation that happens over here, but the function and the filtration is affected. You will get a proteinuria. So when you get red cells, you know where you need to focus, where the inflammation is. When you get proteinuria, you know where you are going to focus, where there are inflammations. Same thing, like if the membrane is affected, membrane becomes more porous and let the protein alone. Without an inflammation, you might get some membranous nephropathy. There is another variant. You will have inflammation or reactive processes that happens in the mesenterium itself. The cells interperse and they control the functions of podocytes. And whenever there is an injury, they try to proliferate and they try to seep in between this gap, between the endothelium and the basement membrane. They try to create another new membrane to protect the filtration. That's what is called membrane gets proliferated. You get membrane or proliferated glomerulonephritis. This inflammation over here, they can affect the glomerular basement membrane. They can have bit of a red cell. That is because of mesenterial cells. They correlate with the podocytes. You'll get some proteinuria as well. So you might get some nephrotic kind of a presentation when it happens. But this is a very simplified process. But you need to know there could be overlap. When there is an inflammation in the endothelium, there might be associated inflammation without any cellular things in the podocyte. So you'll get, despite having a inflammatory process and red cells, you'll also get nephrotic syndrome. When you get a nephrotic syndrome, you might be associated with secondary mesenterial proliferation because they want to control the podocytes. And because the podocytes get controlled, you might get some red cells in between that. So depending on the endocapillary injury, you will get hematuria, loss of EGFR, proteinuria, and you'll get inflammatory lesion. When the injury is outside, when the podocytes or membranes are affected, you get nephrotic range proteinuria and a non-inflammatory region. When the mesangial is affected, it could be either reparative process or primary process itself, you will get bit of a proteinuria and you get bit of a red cells. I think when you get to see a patient, when you see a glomerulonephritis, with the clinical picture, whether you have to define it's an acute glomerulonephritis happening within the endocapillary space, or you have to imagine whether something happening with significant proteinuria outside the capillaries, whether it's affecting the podocytes and the membrane, or is it a mixed picture whether there could be a mesangial inflammation. From the history and the examination, so we'll get an idea what kind of a glomerulonephritis that's happening over here. So that's all the spirit. That is the only slide. I want you all to focus high. When you get a glomerulonephritis, how are they going to come to us? As I said, depending on the injury site, generally we come across the glomerular disease only through the urine report. There's nothing much. Everything is there. Clinical history is there. There is investigations there. But literally, you refer a person to the nephrology or suspect glomerulonephritis based mainly on the urine report. And you have to exclude whatever the changes that's happening. It's not of non-glomerular affair. You have to make sure it is not the urethra inflammation. It is not the bladder. It's not the stone somewhere else. So it reasonably clinical history and maybe with investigation excluding, or to an extent from the clinical history there is unlikely to be a non-glomerular origin. Then you think about it's of glomerular origin. And when you get the urine reports, there are only few things that you could see. Very simplified. You get a urine report, only protein. There is no red cells at all. The only protein. The protein might range from up to 1 gram or up to 3 grams of nephrotic, or more than 3.5 grams to say it as a nephrotic. So you can get only protein. There is no red cells. There is no pus cells. The proteinuria would vary according to the severity of the disease. It might be very minimum to an extent less than 0.5 grams or 0.5 to 1 grams, or less than 3.5 grams or more than 3.5 grams. So when we are very worried is if you have a condition that might cause a kidney injury, say SLA, if you have a proteinuria of more than 0.5 grams, you need to look in whether there is an active disease going on, and then you may have to do a biopsy and classify what's going on. But if there is no secondary condition that is associated, we can accept to a degree with very cautious up to 1 gram of proteinuria, because when we find out the disease, we might not tend to immunosuppress the patient. Only with severe nephrotic syndrome or significant proteinuria or with an association of red cells that we may have to aggressively go, that might be in consideration of nephrotic syndrome. So when you get the urine report, you say it's bland or not, there is no red cells. Then you quantify the proteinuria. They say it's less than 0.5 gram, or whether it's less than 1 gram, or either it's subnephrotic, or it's a significant nephrotic. Then you need to know the conditions with which there is an association with nephrotic syndrome, subnephrotic syndrome, or minimum proteinuria. Then you can work out on the differential diagnosis. Other option is it's more than the protein, it's the red cells. As I've said, it's in the endocapillary space. It's very inflamed, and you're going to get only red cells, and the red cells would be dysmorphic because they had to travel through different concentration gradient of urine within the tubule. They get dysmorph, they call it as dysmorphic red cells. Because the red cells seep, they form the cast, and you call it as the cast. And that is what is called as an active sediment. This is quite an inflammatory thing that is going on. We need to be aggressive on it for this to salvage, because the inflammation is going to heal with scarring, and there is going to be permanent damage with it. So in this regard, only one thing that I would like to specify in dysmorphic red cells, because even if you put red cells in a stagnant urine in the bladder itself, the form would get deformed. Not because it just travels through the tubules. So interpretation of red cells needs some expertise. Not everyone can really say whether it's a dysmorphic red cell. There are people say there are about 15 types of different forms of dysmorphic red cell. So if you say someone says it's a dysmorphic red cells, my question is who saw it and whether he has got some experience in seeing the dysmorphic red cells. It's preferably that for the clinician or the nephrologist to have it and say it as it's a dysmorphic red cell. So that is one thing. Second thing is it could be asymptomatic as well. So not just because the patient has no other symptoms, just because though there is no systemic symptoms. You have, if the patient gets an active sediment, you need to be aggressive in taking up the diagnosis. Maybe you have to first exclude the glomerular origin of it, but if there is a renal impairment, it could be a very active disease without any symptoms, and the kidney might be dying silently. So you need to be aggressive. You need to be very, very focused. Few conditions, it can be only the renal limited disease. So it might present with the glomerulonephritis, high blood pressure, increased serum creatinine, and active sediment, no other system involvement. So we may have to think it's only a primary renal disease or renal deficit disease. We need to be very careful when you have a secondary disease that might cause a renal involvement. Typical example might be a cell. In other conditions, I might accept a bit higher degree of proteinuria before I would immunosuppress. But if there is a secondary condition, I would be more aggressive because I know the secondary condition itself, it's an inflammatory in nature. So there is a likelihood of inflammatory lesion that's happening. I can control the inflammation with immunosuppression. So I would be more pro for renal biopsy and see what's really, really going on. So generally my threshold for doing a renal biopsy and finding what is the inflammatory lesion would be very less if I am suspecting a systemic disease or I am suspecting a secondary renal involvement. So this combination can happen in nephritic and nephrotic picture. There is a nephritic range of proteinuria. There is a nephrotic range of proteinuria. Generally, it happens, as I said, the mesangial cellular involvement, mesangial membrane of proliferative glomerulonephritis, or mesangial proliferative glomerulonephritis with IgA deposition. And the third degree we have to be worried about is one of the active sediment, one of the active diseases, because the person has a secondary disease, it has been treated, partially treated also can present typically. But there might be overlap between the things, and this would be the accepted normal frame to look into the glomerulonephritis. So I look at it, I look at the glomerular disease, and I look at where might be the inflammation. Then from the investigation, I like to see whether it's a severe lesion, whether it's an active lesion, or it's a combination of lesion. Then I would like to think might be the origin of it. So I'm going to go for it in the sense, in an infection related, that's what generally happens in the hospital setup. Infection might precipitate an acute glomerulonephritis. Common infection as streptococcus, staphylococcus, and other associated common infection, and chronic infections as hepatitis B and C also can precipitate glomerulonephritis. Infections, even MRSA, can precipitate an infection-related nephrotic syndrome as well. So the patient has a definite infection, might be a cutaneous infection, might be a community-acquired infection. That infection itself would cause a glomerulonephritis. And the outcome would depend on the treatment of the primary infection itself. And we expect when the infection settles, the glomerulonephritis should settle as well. If not the case, or if there is a suspicion of a secondary pathology, we would be aggressive. Or at that time, if we can reasonably correlate, the infection is the one that is precipitating a glomerulonephritis, or infection is the one probably worsening, presenting with the nephrotic syndrome, we could wait till the infection settles, but with the caution, there is no secondary pathology identified or concerned, or there is not an RPGN or very severe or unexpectedly severe glomerulonephritis, then we may have to be aggressive. Here the point is, at this happen, are we going to treat the infection or are we going to immunosuppress? In the context of infection, we might opt for treating the infection. When this is not there, then we might have to think about what are the other things. Go to the glomerulonephritis. In generally thinking, if a patient comes with the glomerulonephritis, maybe a proteinuria with red cells, I would think about the classically what I would think about is the Alport syndrome. So Alport syndrome is a patient who have proteinuria, bit of red cells, and also extra-renal manifestation because there is an abnormality of the collagen 4 alpha 3, 4, and 5 within the basement membrane. You get similar things in the cochlea of the ear as well. And these patients would have a kind of a proteinuria with red cells, as well as they would have some hearing impairment, and they might have keratoconus or eye involvement. So this combination would tend towards an Alport syndrome. It's inherited. I will have to look in carefully for a family history and see whether it's there. But always remember, not all renal impairment with hearing impairment is Alport. You have to have a reasonable suspicion. But when you do a biopsy, you will say, because the pathology is in the basement membrane, you will get a lamellar or multi-layered basement membrane characteristic. It happens quite lately. Thin membrane disease is quite a benign kind of a condition. People say Alport syndrome and thin membrane are the same disease with different spectrum. One is in the higher end, thin membrane is the lower end. You get some only red cells. Very rarely they might progress to end-stage renal failure. Literally, they do not progress to end-stage renal failure. They will get episodic red cells, especially associated with intercurrent illnesses. Always in proteinuria, always think about familial conditions of significant proteinuria, familial FSGS. It's not rare as you might expect. We have about 3-4 families in a million population, might be say in Jaffna itself. So it's not that rare. Familial FSGS are common, especially in communities where you have consanguineous marriages as well. So focus on that aspect. Then in regard of it, as I said, glomerulonephritis and glomerular diseases are quite interchangeable. Then diabetes mellitus and hypertension itself is a glomerular disease as well. So we have to be careful in two contexts. One is diabetes itself is a pro-inflammatory condition. I would say you would check for high sensitive CRP, that will be elevated. Hypertension, to an extent, when you get a renal impairment, I would say there is kind of an inflammation. Maybe you will not see cells there, but there is a proliferation of mesangial cells or secondary FSGS or cytokine chemokines are elevated or transformation growth factors are elevated. So there is a bit of an inflammation. So you can't really see the glomerular diseases are not without inflammation, but it's not a glomerulonephritis in a classical sense. There is no cellular active proliferation as well. But the wariness comes in the prevalence of diabetes and hypertension, because you expect about 20% of the population to be affected by diabetes mellitus, and the hypertension prevalence above the age of 40 would rise up to 35 to 40%. In that context, they can have superadded pathology, any of it as well. So just because a patient has a diabetes or just because a patient has a hypertension, we can't make out it is the diagnosis. It may make out other way around. Sometimes these, because they are inflammatory in nature, they might mimic mildly inflamed glomerular picture, and we might unnecessarily tend towards the immunosuppression as well, especially diabetic, whether you get some mesangial proliferation, maybe a secondary FSGS that comes into picture. Then if we are very desperate, we might wrongly treat the patient, even though there is no glomerulonephritis. So you need to be wary about that. As I discussed about, the injury, whether it's an endothelial injury or whether it's in the basement membrane or whether it's in the podocytes or whether it's the messenger, it could be antigen driven, maybe an intrinsic antigen, or maybe an antigen that comes and fixes it, maybe an antibody antigen complex, immune complex, or it could be a complement mediated effect as well. The complement mediators is, we don't generally looking for the complement levels on activity. We're looking for the biopsy and deposition of whether it's immunoglobulins that stains in the biopsy. Then we might say immunoglobulin mediated. Immunoglobulin and complemented, so we think complements, immunoglobulin binds to complement, again immunoglobulin mediated. But immunoglobulin is not there, only complement deposition is what you see in the renal biopsy. So you do the renal biopsy, you get some proliferative lesions, but you would stain for immunoglobulins. It's not there, but you stain for the complement, you see the complement. You can characterize the complement further and say whether it is a complement mediated proliferative lesion or deposition disease that's happening in the kidney. So immunologically, I want to think whether there is an immunological component going on in the glomerulonephritis. Could this be immunoglobulin mediated? Could this be complement mediated? Also, as I said, depositions of abnormal things also would evolve an inflammatory response. Maybe a abnormal immunoglobulin gets deposited over there, and when the abnormal immunoglobulin, they fold among themselves because of the chemico-physical properties, and they will evoke an inflammatory response. That might be something to relate with light chain disease, paraproteinemia, amyloidosis. When it, then generally it doesn't get defined only to kidney. There might be other areas involved, but when you get that in the kidney, it might be a disease defining. Because the kidneys are affected, we may have to aggressively treat the patient as well. So that's what I said. We look into that. We think where the inflammation is happening. With the urine report, we try to focus what's the degree of proteinuria. Then we need to focus on the red cells. And then we think whether it's antibody mediated or whether it's no antibody deposition, it's only complement mediated. But we don't see any inflammatory cells. There is inflammation, but we don't see active inflammatory cells happening. So it can happen, as I said, it's beyond the basement membrane, maybe in the podocytes, maybe in the slit gaps. Then you will see a minimal change. You do the light microscope, you will see nothing at all. But if you do an electron micrograph, then you will see the effacement or flattening of the podocytes. The soldiers are not standing straight. They might be lying flat, protecting the glomerular basement membrane. That's what is called the minimal change. But there is an inflammation in the sense cytokines are there, chemokines are there, growth factors are in place, but we don't see it in the light microgram. We don't see cellular infiltration. Similar picture could see in the focal segmental glomerular diseases as well. You need to think about a patient who has an atypically very high proteinuria, but there is an active inflammation. But in active inflammation, you don't see very high proteinuria. In that condition, we might have to think with an active proliferation whether there is an associated minimal change kind of a disease going on as well. It's not always the inflammation, it's not always the cells, it's not always the antibodies, it's not always the complement, it's not always the chemokines and cytokines. It might be inflammation or microthrombi that's happening within the vessel itself. The vessels get endothelium gets damaged, then the platelets get activated, platelets get deposited, they disrupt the circulation, then you get the microthrombi, and you will get a similar picture to glomerulonephritis, because glomerulonephritis, glomerulosis made up of vessels. It can be blocked by the inflammation, or it can be blocked by the thrombi itself. So you will get similar pictures in TTP-HUS complex or MAHA kind of a picture is what you see as a consequence in the black picture. Vasculitis itself, inflammation of the small vessels. Kidneys are filled with small vessels, and when the glomeruli is inflamed, you'll see the vasculitis that's happening over there. Coming into it, we talked about it when we do a biopsy. What we need to know about the biopsy is one thing that is very, very, very important is we need to have a working diagnosis through all the steps that I've explained. There is no point in doing the biopsy without a working diagnosis. We need to have a pre-test probability. What is it? Is it infection related? What it is? It is complement related. Is it immunoglobulin related? Is it a chronic infection? Is it a systemic disease? Is it an acute glomerulonephritis picture precipitated by maybe a post-streptococcal, maybe some medication that we may have given? So we need to have the diagnosis beforehand. Then, because all the investigations have a sensitivity and the specificity, and that will be influenced by the pre-test probability as well, because one disease can have multiple patterns. The typical example we'll say is they can have minimal change, they can have IgA pattern, they can have minimal mesangial expansion, they have a proliferative, diffuse proliferation, they have a segmental proliferation, they can have membrane. So you see a pattern. We don't see diagnosis in renal biopsy. We only see the pattern. Diagnosis is actually need to have a pre-test probability, and also you need to know how common is the disease. Prevalence of the disease is also influence the pre-test possibility and a diagnosis. And for me, I would say one disease can have multiple patterns. Multiple patterns can be seen. One pattern can be seen in multiple diseases as well. Typical example would be membranoproliferative glomerulonephritis. You can see in thrombotic disease, you can see in autoimmune disease, you can see in paraprotein disease. Just because you see a membranoproliferative glomerulonephritis, unless and otherwise you have a diagnosis working beforehand, you would not be able to make up a diagnosis. And the final diagnosis is not when the biopsy is done. Final diagnosis is, I would say, when the patient comes to the clinic and the treatment response and the tail of the patient. That is what, when we make the final diagnosis, this is the diagnosis. So you should have to look into it, the inflammation, where are the inflammation, what drives the inflammation, What is the pretest probability? Then do you do the biopsy? Then you have a working diagnosis. Then you start the treatment. Then you make a final diagnosis, possibly and preferably, I would say, after a solution. So when you do the biopsy, how are you going to look at the biopsy? It's quite simplified. If you would, it's not very like kind of a rocket science. It's just the terminology. If you can know the terminology, then we know what we are being talking about. First thing would be whether the inflammation involves all the glomeruli. In the sense, all the glomeruli we have biopsy. If more than 50% of the glomeruli we biopsy, say we do about 10 glomeruli is seen in the biopsy. If more than 10 is affected, we say it's a diffuse process. More than 50% of the glomeruli of the biopsy sample shows an inflammation or changes, then we can say it's a diffuse process. Only less than 50%, let's say again we say 20 glomeruli, less than 10 glomeruli show changes and other glomeruli are absolutely normal, then we would say it's a focal lesion. Then the terminology is segmental and glomerulus. Within the affected glomeruli, is it the whole glomeruli is affected? Then we say it's a global affection of the single glomeruli. If only segment of it or only a part of it, then it's affected, less than 50% of the glomeruli is affected, then we would say it is segmental. The process can be affecting all glomeruli, then it's diffuse. The process can be affecting less than 50% of the glomeruli, it's focal. Whole glomeruli within what we have sampled is affected. Only a part of the single glomeruli is affected, then it's called the segmental. Necrotizing, whether we say that because of the inflammation, because of the necrosis that's following the inflammation, can you say the karyorrhexis or debris of the nuclei, then we would say necrotizing. Crescens is when it seeps out of the basement membrane, the disrupted basement membrane, the Bowman capsule is filled with inflammatory cells, and there is a reactive proliferation of the parietal epithelial cells outside that forms the typical crescent appearance in the biopsy. Then we say it's crescentic glomerulonephritis. It's just the terminology. Then we can have focal segmental necrotizing glomerulonephritis. Then we can choose diffuse proliferative global glomerulonephritis. Then we can choose diffuse segmental glomerulonephritis. We can have a combination of these things and make up a diagnosis. What's really going on? This is in regard to the light microscope and the stains what we see. But when you have the immunoglobulin stain, when you have the complement stain, then we can further subdivide. So you can say focal segmental glomerulonephritis, where the immunoglobulin is deposited. Is it in the subendothelial space, or the immunoglobulin are seen in the membrane, or is it seen outside the epithelium? Is it the subepithelium? Or it is only the immunoglobulin that is seen, but there is no immunoglobulin, or is it only the complement that we are seeing over there? So after that, diffuse proliferative glomerulonephritis with subendothelial immunoglobulin deposition, or membrane proliferative glomerulonephritis. We see the immunoglobulin deposition in the subendothelial space. That will give a further characterization of the pattern that we see in the renal biopsy. Remember, it's only the pattern that we see in the renal biopsy. The diagnosis is made through the pre-test probability, and then through that we make a diagnosis. Combining all these together, you have a glomerular kind of a picture. You have where the inflammation going on. Then you look into the urine and you see the severity of the involvement with the presence of red cells, with the presence of activity, with the presence of proteinuria. Then we do a biopsy, and the biopsy we see different patterns, and we have different terminology, whether it's focal, diffuse, whether it's segmental, global, whether it's crescentic. With this pattern, then we make up a diagnosis of what's really happening. So if the patient presents with more of a proteinuria, this end of the spectrum is likely to be the diagnosis. If the patient presents with more of an active or virulent or fulminant or rapidly progressive glomerulonephritis, this end of the spectrum with hematuria present would make more of a diagnosis. The patient comes with significant nephrotic range proteinuria. As I said, injuries beyond the basement membrane in the podocytes. There is a change in architecture. Might be a reparative process that might be happening. This, if you see nothing at all, you call it minimal change in nephropathy in the light microscope. You get focal, segmental, glomerular sclerosis, then you say FHGS. If it's membrane thickened with immune deposition, we might call it as membranous nephropathy, and amyloid deposition and staining for conglomerate. This typically would present towards proteinuric disease. Other end of it, there is active inflammation in endocapillary space. There is cellularity there. There is mesangial, no, there is endocapillary hypercellularity. There is neutrophil present there. There is reactive mesangial hypercellularity. This would make towards a necrotizing lesions and crescents, and might present with rapidly progressive glomerulonephritis, which is a medical emergency. Because the inflammation is so severe, it will affect the kidney very rapidly, and if we don't act on it, more number of glomeruli will be recruited, and you might end up with long-standing failure or long-standing acute kidney injury and a poor recovery. So this instance, we need to be very aggressive on it. Typical would be small vessel vasculitis and anti-glomerular basement membrane disease. This you need to be very aggressive. Generally, if it presents with RPGN, we need to be working within 24 hours to 48 hours to make up the diagnosis and start treating to reduce the inflammation and reduce the scarring as the sequelae. And other typical example that we study is any glomerulonephritis. The typical or the frame that you need to study from is post-streptococcal nephritis. Study this one, then you study how is it different from anti-GBM, how is it different from small vessel disease. This is the structure. Very rarely, in about 1% of the patient, post-streptococcal glomerulonephritis can present with crescentic glomerulonephritis as well. In regard to proteinuria, minimal change is the basic pattern you need to study about it. Then you need to learn about how does it differ from FHGS, how does it differ from membranous nephropathy, how does it differ from amyloidosis. And in between, you get the commonest glomerulonephritis of IgA nephropathy, generally presents with hematuria and bit of a proteinuria. Very rarely, they might also cause some active crescentic glomerulonephritis. And this is the most commonest glomerulonephritis that we see in life. And to be sad about it, no one really know how to treat it, even in the primary glomerular IgA nephropathy. But if you have a secondary IgA, secondary to infection, or maybe a condition with cirrhosis, maybe a condition with celiac disease or inflammatory heart disease and association, it makes our life even more difficult. As I said, SLE can have a spectrum for proteinuria to have a very active RPGN. So we need to decide within SLE. For SLE and other diseases with secondary renal involvement, I will be having a lower threshold to be aggressive and finding out the diagnosis. When it comes to diabetic nephropathy, one condition that we need to look into is the sequence of elevations of proteinuria. So very often what happens is a diabetic patient would come with the proteinuria over 3 grams. You look for it through the records to see have they ever documented a proteinuria, microalbuminuria. Patient would have gone to clinics for ages and ages, and they have never documented the urine report of the microalbuminuria. It becomes very difficult for us to say whether this proteinuria is of sudden onset or whether it's a gradual onset. The typical gradual onset history, if we can prove it, for me, that is the diagnostic thing that makes it a diabetic nephropathy. In the absence, it makes the life more difficult. And I would say it's a crime if you get a diabetes patient and you don't look into the microalbumin or proteinuria and document it clearly for ages to come. That will guide us in the easy diagnosis for us. I think it's a responsibility for every clinician to look into the microvascular complication, microalbumin, in a very regular basis and document it clearly as well. So how are you going to investigate it further? I will not be going in deep of it. So I'll take the minimal change disease, which is the focus or the model disease for nephrotic range proteinuria. Happens in children and it happens in all ages, even in adults as well. There is no specific investigation that we might go. We only look into the nephrotic syndrome and investigation. Biopsy, we confirm the diagnosis in adults. There is association with non-steroidal anti-inflammatory medications, maybe a hypothyroidism, maybe a lymphoma. When this happens, we may have to look in for maybe whether there is an associated secondary condition. More or less, the primary FSGS would follow the minimal change, but the age of onset, rather than being children, it might happen more frequently in young adults, and the investigations are quite non-specific. Membranous nephropathy, again, as I said, it's in the proteinuric spectrum, happens in middle age and all the adults. We can do, it's been done in Colombo and few private sectors in Colombo, antiphospholipase A2 receptor antibodies. If that is quite positive, that might suggest towards a primary membranous nephropathy. Our worry is membranous nephropathy can be secondary to chronic infections, or it can be associated with solid organ malignancy. So if your patient gets a membranous nephropathy, if you have the APLS, that might be okay. If it's absent or not available, you have to look in for age-appropriate cancer screening. But you have to be careful. You don't have to chase behind a cancer. But age-appropriate cancer screening should be carried out for it. Amyloidosis and high ESR and serum protein electrophoresis, all recurrence events that happens in medical wards regularly. Please keep in mind, when you get a significant nephrotic syndrome for other causes, when you get the CKD above CKD stage 3, 4, and 5, there is significant number of patients associated with high ESR itself. So just chasing behind just a high ESR or reasonably mildly elevated ESR, you have to be wary in our economic context and the stress we put on the patient in evaluating ESR. Keep in mind, end stage or CKD stage 4 and 5, severe nephrotic syndromes can be associated. Same thing when you get the nephrotic range proteinuria or diabetic nephropathy with proteinuria, Ben-Jones protein can become positive, because Ben-Jones protein means it's a immunoglobulin. It's a light chain immunoglobulin. Light chain immunoglobulin can be synthesized as a secondary response, maybe in nephrotic syndrome, maybe in chronic inflammation. And because the tubules cannot reabsorb all the light chain, they might come into the urine. So Ben-Jones protein would say there is light chain in the urine, but it doesn't say a monoclonality to suggest towards the monoclonal gammopathy. So be wary about it, but you can't neglect it. We definitely need to look into it, but also look in the overall picture of the patient, especially if the patients are quite elderly. And yes, I would agree for it, but also taken the disease burden on the patient population as well. Diabetic nephropathy depends on the duration of diabetes and the sequential elevations of proteinuria to microscopic proteinuria, microalbuminuria, overt proteinuria, nephrotic range of proteinuria. That might give us clue for the diagnosis, but it doesn't always follow the typical course of it. There are, because of our food habits and because of our sedentary lifestyle, we are more and more seeing rapidly progressive CKD and rapidly progressive end-stage renal syndrome, where they are maybe serum creatinine of 150 and they end up being dialysis in 3 to 6 months' time, and the only diagnosis being diabetes mellitus. And we need to take a learning point in diabetes. We need to start early in controlling the diabetes. We need to start early in controlling the hypertension. We need to start early in controlling the dyslipidemia. We need to have smoking cessation, lifestyle changes, not just for 1 year, not just for 1 month, not just for 1 year or 5 years. At least minimum of 5 to 10 years of persistent control is what is going to give diabetic good outcome. The patient comes to me and says, I have my diabetes controlled for a week, for a day, for the month. It doesn't make any sense for you. Had you had your diabetes controlled for minimum of 5 to 10 years, that's what it shows in the UKPDS. When you control it for prolonged control, that's what is going to make a difference. And that's what we need to focus. And it needs to start not at the CKD stage 3 and 4. We need to start at CKD 1 and 2. That is the time we need to invest on diabetes. That is the time we need to invest on pressure. That is the time we need to invest on proteinuria as well. Just to take up record, because I've been going continuously. So we have heard about this Harvard problem that's been happening. That they generally go with the trolley and the response. There is one investigation, just imagine that investigation have a false positive rate of 5%. If you have doing the patients, we are doing the investigation for 1,000 patients, only about 50 patients would have a false positive result. In 1,000 patients you do the investigation, 50 people would show a positive result saying that disease might be there. what will happen if only 1 in 1,000 gets the disease? And we do the investigation without the pre-test probability and say, this is the disease the patient has. Very, 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 very careful about the prevalence of the disease. This is, you will never get 100% sensitive and a false positive 5 patient. You only get sensitivities of 80s to 90s. That's what we typically see. But if you have a 95%, the best investigation, if you do 1,000 investigations, 50 would say a positive result. But if the prevalence is 1 in 1,000, prevalence is quite rare in our context. How are you going to interpret it without the pre-test probability? So always, 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 what makes the diagnosis is the history and your thinking process, not the investigations, even though that investigations and biopsy would support and I would confirm our diagnosis. In that context, we need to look into the ASOT. Not just because ASOT is there, that is the diagnosis. Absence of ASOT doesn't exclude any diagnosis. Everyone wants to do IgA levels, which has no place at all in IgA nephropathy, because we are not looking at the IgA. We need to look at galactose deficient, what kind of an IgA is there. Just doing an IgA is unnecessary expense to the patient, very widely precipitated. But in the context, you can have secondary IgA diseases in liver cirrhosis and other diseases as well. But we don't even really know how is the best method of taking IgA nephropathy. Secondary IgAs are quite difficult for us as well. Just focusing on secondary IgA, we may have to treat the primary or the disease that causes the IgA might be a better option. So in regard to few investigation, we need to know investigations done outside, whether it's really needed, we may have to do it. But if you have a biopsy facility, a nephrologist available, they will do a biopsy and narrow down what might be the investigations needed. And that will guide us to do the selective investigation. We have had a patient, we are dealing with the patient in the COVID time, and we make up a diagnosis. Then we have multiple layers of investigation driven by HOs, registrars, senior registrar, other consultants. And one of the cases where in the COVID time, we have requested all the investigation and the patient ended up paying 150,000, bringing the lab to the hospital because we have made sure that all the investigations are done. Where it could have been avoided by doing a biopsy and doing a selective investigation if it's not a life-threatening or if it's not a serious. So be selective, be concerned about the economic constraints as well. So in the or everything, the last slide again, we're going nearing it. Rapidly progressive glomerulonephritis is what we need to be very focused. We can't miss about it. Always think about primary and secondary vasculitis. Think about anti-GBM disease, and also think about the glomerulonephritis and IgA nephropathies can present with a very severe, rapidly progressive glomerulonephritis. Infection-related glomerulonephritis can also prevent with rapidly progressive glomerulonephritis. In relation to glomerulonephritis, male sex, as always, they have the disadvantage. They have a poor prognosis. When the patient has persistent hypertension, the prognosis might be poor. Persistent proteinuria, which is not responding, prognosis might be poor. Serum creatinine at the time of admission. Always recognize that glomerulonephritis at the earliest stage. The serum creatinine with which the patient presents decides what's going to be the prognosis. When you do the biopsies, the chronic changes might decide what needs to be done. When the patient has chronic changes and there is permanent damage, we might be poisoning the patient if we are giving immunosuppression, despite knowing the chronic changes is going to perpetuate the renal failure. So we have to be selective in case of the immunosuppression. We may have to accept our defeat in glomerulonephritis and say, we are failing here, it has gone chronic, I'm not going to immunosuppress this patient any further, I'm not going to poison the patient. That we need to be keeping in mind. Minimal change disease, we all know about it. If it's relation, if it's react to it, stays with steroids. If it's not, we may have second or other line agents that's driven by the nephrologist. FSGS, here FSGS, I would like to vary in one thing, what is called as secondary FSGS. When the nephron mass, the number of glomeruli is less than what it should be, maybe because of a previous injury, maybe because of a previous glomerulonephritis, maybe your workload is high as if you are obese, that will cause hyperfiltration and proteinuria. There would be some reactive changes in proteinuria. These patients are generally not that edematous, and serum albumin is generally within the normal range. And these patients should not warrant immunosuppression. We need control of the secondary stress events that we need to look into. Always keep in mind whether it's a secondary FSGS in a chronic setup When there is an hypoalbuminemia, albumin is less than 20, in high-risk individuals, we may have to think about anticoagulation, DVT prevention. When the patient is nephrotic syndrome, be careful about the OCP and contraceptives that might provoke a thrombotic episode, especially in people who are having albumin less than 20. Then anti-GBM disease presents with RBGN, and we can't miss the diagnosis. We may have to go for pulsing, and we may have to go for plasma exchange at times, even without the biopsy or waiting for investigations. Same thing would apply for vasculitis, but be careful, vasculitis can happen only in the kidney itself. Again, in PGN, we need to have a pathophysiological mechanism, how the injury is happening, if it's immunoglobulin dependent or is it complement dependent. IgA nephropathy, it's a common as glomerulonephritis. It depends on a scoring system to decide what the prognosis is, but there is always secondary IgA nephropathy related to infection, related to liver cirrhosis, celiac disease, autoimmune diseases, inflammatory bowel diseases. And these conditions generally treated by treating the primary condition itself. Maybe in few exceptional circumstances, we may have to control the inflammation within the kidney. SLE, there is no excuse we can miss SLE. SLE type 3 and 4, we need to be aggressive with the treatment. And this patient, SLE nephritis, respective of the stage, respective of the whatever is happening, if there is a renal involvement, it should be followed by the nephrologist. And nephrology input is very, very, very essential in managing SLE. And we need to absolutely make sure there is no renal involvement. We should have a low threshold for them to do. This is going to be my last slide. This is focused on 3 aspects of it. When you get to glomerulonephritis, you make the diagnosis, you suspect the diagnosis with the clinical picture and then the pathophysiological mechanism. You recognize the pattern and you confirm the biopsy with the supported by other investigations, and you treat the patient and you wait for the response. In between, the hypertension needs to be managed effectively, proteinuria needs to be managed effectively, and more importantly, patient needs to be managed for edema as well. In regard to hypertension, sodium restriction should be in place. Generally, glomerular diseases are sodium retaining diseases, so salt restriction should come into place. 2 grams of sodium or 5 grams of sodium chloride is the definition. Moderate protein restrictions, there is no point in giving too much of protein because he's leaking protein. That will further make the protein to leak and cause secondary proteinuric injuries to the kidney. We can't reduce the proteinuria. That's because the patient might go malnourished or cachectic. So we may have to go for normal protein intake or marginal reduced protein intake, because the protein would cause a vasodilation and therefore an arterial. That might be the reason. Always think about other diseases when you think about kidney disease. It's not the kidney disease that kills the patient. It's an associated cardiovascular disease, associated MI, associated stroke that kills the patient. Whenever the patient with the CKD, always think about the heart. Lifestyle changes is part and parcel of glomerular disease, because we want to prevent the cardiovascular disease. Impression, always think about whether there is a place for angiotensin converting enzyme inhibitors. But this is for chronic glomerulonephritis. Don't think about it unless and otherwise you're suspecting specific diseases as systemic sclerosis, ACE inhibitors. In an acute glomerulonephritis, we have to choose the right time for it. But in a chronic glomerulonephritis or hyperfiltration injury, FSGS, that needs to be the first. Diuretic, rationalize it. Don't over-diurese the patient. Always aldosterone mechanism has to be blocked. Calcium channel blockers is good in regard to proteinuria. There is suspicion of amlodipine might cause some proteinuria. This is unsupported. There is always amlodipine for the blood pressure control. If the blood pressure control is achieved, the proteinuria is achieved as well. But most important thing in that regard to calcium channel blocker, diltiazem might be preferred. Amlodipine, cilidipine can be used to control the blood pressure. There is minimum concern regarding amlodipine-induced proteinuria. More of it is overall blood pressure control that proves the way. Always concerned about when the albumin is less than 20, when the patient is going for contraception and OCP for thrombotic risk. Immunization when the patient is on immunosuppression. they are at high risk of it, whether at timing of immunosuppression looks to treated. And despite that, there is specific treatment that should be driven by the nephrologist or the respective underlying owner of the patient. For that, I'm going to complete my whole stretch of things that I've said about this. If you have any questions, I'm quite happy to answer. Hello there. Are you with me?
Thank you, sir. So on behalf of the Society of Health Research and Innovation Sri and the Government Medical Officers Association and the Sri Lanka College of Internal Medicine, I would like to extend my gratitude and appreciation to Dr. Brammah R. Thangarajah, the consultant nephrologist of the professional unit of the Teaching Hospital, Jaffna, and the senior lecturer in the Department of Medicine, Faculty of Medicine, University of Jaffna, for enlightening the junior professionals on the topic of the overview of glomerulonephritis. So we would be moving on to the question session. So prior to that, I would also like to take this opportunity to extend my acknowledgement to Dr. Ganaka Senaratne, the president of the Sri Lankan College of Internal Medicine, and Dr. Mrs. Nandini Nyanaprakash for coordinating this forum through the college. So we would be moving on to the session on question and answering.
So should I be reading the questions and answering? Yep, that is. Yeah, I'll do that. The first question is from Sharmi, and she wants to quantify urine 1+, 2+, and 3+, and roughly to the proteinuria. So I might be a bit wrong with the numbers. One would suggest to 30 to 100 milligram. 2+ might be 300 to 1 gram. 3+ above 1 gram to 3 grams. 4+ might be nephrotic. But I have to an extent given up on relying on the ward test in regard to urine proteinuria. It gets quite murked by the way that we do it, and it's quite unreliable. I would prefer to say if the patient is grossly nephrotic or mildly nephrotic, it might give you an idea. It might give you an idea to see the follow-up. It's responding a bit 3+ to 1+. I would not be making diagnosis based on urine 1+, 2+, and 3+. I always wish to quantify the proteinuria, and it's an absurd thing unless and otherwise it's indicated to go for a 24-hour correction. It's cumbersome to everyone. It's cumbersome to the unit. It's cumbersome to the patient. Don't ask routinely for 24-hour proteinuria excretion. Urine protein creatinine ratio spot 1 is well validated even in children, even in pregnancy. Don't really push for a 24-hour protein creatinine ratio, but there are exceptional situations where you need to be minutely monitoring the proteinuria, or the proteinuria amount might vary. Then in that context, we might go for a 24-hour proteinuria, but I would prefer not to relate on the UFR alone, 1+ and 2+ and 3+, but it might guide in the long follow-up when we have resources. Maybe if you're going to see a patient, you're going to start on immunosuppression, and you see the response, you don't have to see the urine protein creatinine ratio every month. So you do a protein creatinine ratio, then you follow up 2 or 3 months with urine reports, then you see the response with protein creatinine ratio. But it depends on what kind of a glomerulonephritis that might be. I think hopefully I've answered it, or I might have blabbered a bit through, but I don't really recollect the numbers. But I think 1+ is 30 to 100, 2+ is 100 to 200, so it might vary up to it. So please check that aspect of it. Is there a difference between plasmapheresis and plasma exchange? I think plasmapheresis and the plasma exchange I think the plasma exchange, it's an old terminology where you take the blood, separate the plasma, and take the bad part and give it back. So that's what the plasma exchange word comes. Plasmapheresis itself, when you are doing the process, then and there itself, you are able to take the unwanted plasma from it. So it can be done in 2 ways. One is using the centrifugal force when you have and you roll the plasma and the blood. So in different weights of the molecule, they will get sedimented in different places. Then you can choose where the immunoglobulins are got sedimented, you can take it out. That is one way of doing plasmapheresis, in the sense it happens at the time itself. That might be the exact reason for it. And the second thing is, now you have the filters as well. The CRRT machines are quite equipped with filtering way of plasmapheresis. They can filter the immunoglobulins out. That is also equally effective. That if you don't have a transfusion specialist available, or it could be done if in a place where the plasmapheresis burden is so high, some of which can be taken by the nephrologist itself. So in the place where they have very well established renal sectors, they might do the plasmapheresis through a filtration process by themselves. Plasmapheresis might be for an academic interest. It has a place when you are thinking about the blood group incompatible transplant. Then you might take out the offending antibodies using the filters. It's more or less similar to plasmapheresis as well. I think it's the generation that comes from plasma. It's the generational terminology, that plasma exchange and plasmapheresis. Plasmapheresis, in the sense, it happens more or less through a pheretic process at the same time. That's how would I look at it. Then it's from the Pereira. Please explain the treatment methods to manage proteinuria in glomerular disease, managing and controlling in subsequent clinical visits. So it will depend on the glomerular disease. So whether it's a very active disease or whether it's not an active disease. So it will depend on the disease. Second, it will decide on the activity of the disease. The proteinuria comes into place in two ways. One way is proteinuria reflect as a surrogate marker of disease activity. Proteinuria is high, disease activity is high. So that's the way we look at it. Second thing is, proteinuria can be a marker of a damage. So it's a damage of it persistently might be at the lower levels. So we do quantify the proteinuria, and you do what is the disease. Then we correlate the proteinuria to the disease activity, and depends on what is the glomerular pathology. And if it's going for the higher end or chronic nature of a chronic glomerulonephritis, you can make antiproteinuric measures to reduce the number of protein. Because the more the protein is filtered, more the injuries happen to the tubule. Because protein itself is tubulotoxic. Second thing is, proteinuria would suggest there is an increased filtration pressure. Because the filtration pressure increases, the proteinuria increases. We try to reduce the filtration pressure with ACE inhibitors. Now in place, especially in diabetes, and probably might be in non-diabetic condition as well, sodium glucose co-transporter inhibitors, empagliflozin, dapagliflozin, they have a tremendous say in diabetes. They reduce the proteinuria, they reduce the filtration pressure, and it's quite good for the heart and kidney as well. And in this patients, we may have to choose the right antiproteinuric agents, and we're going to sequentially monitor the amount of proteinuria, and we're going to monitor the serum creatinine. If it's an inflammatory lesion, active lesion, then the proteinuria would guide us towards, because we have done the biopsy, there is an activity. Proteinuria responded, the treatment is responding. Proteinuria is not responding, the activity is going on, because we can't do the biopsy each and every time. So we do the biopsy, make the diagnosis. We take the proteinuria as a surrogate marker for the inflammation or activity of the disease. Then we titrate the immunosuppression because in condition where you don't want the immunosuppression, you don't think there is a place for immunosuppression, then you control the proteinuria with antiproteinuric measures. So you have to make that distinction whether proteinuria is related to activity of disease or proteinuria is related to the damage or the hyperfiltration. So that's how we are going to manage the patient. Does clinidipine significantly reduce the proteinuria, sir? It's a tough question. Few medications, all the medication, if you control the blood pressure, by controlling the blood pressure itself, that will reduce the proteinuria. So it's not the property of the drug, it's the property of reduction of blood pressure. But there are medications, despite the property of the blood pressure reduction, the property of the drug itself would reduce the proteinuria. Those are characteristically ACE inhibitors, ARB, spironolactone, sodium glucose co-transporter, diltiazem. That the amlodipine in few studies, because when they came first in the first study, they thought it's the wonder drug that is cardioprotective as well. So it was proven to be not so much in the second subsequent study. but it was very cardiac friendly. In that generation, there are few studies to say it might have some antiproteinuric effect, but I would not take it as a first line antiproteinuric. It's because of the blood pressure control. But when controlling the blood pressure, so it's bit more convenient. You can always keep in mind diltiazem can be combined with clinibidipine, amlodipine, ifidipine, and increases the effectiveness of antihypertensive medication. You can't combine verapamil and diltiazem. You can't combine diltiazem and ACE inhibitor. You can always combine non-hydropyridine and non-calcium channel blockers. You can combine clinidipine, amlodipine with diltiazem. Actually, the antihypertensive effect goes up. So I don't mind combining diltiazem and amlodipine. It shows the amlodipine efficacy goes up. Then it will reduces the blood pressure, and in turn it will reduce the proteinuria. There is a bit unsubstantiated evidence to say that amlodipine might increase the proteinuria, but I'm more concerned of the blood pressure control, because when I've come to the amlodipine, I'm coming to say that I need more blood pressure control. Non-hydropyridine and non-dehydropyridine. Those are the classifications. Then from Pavitran Kohiladas, in diabetes patient with trace albuminuria who are on ACE inhibitors with low blood pressure, we are worried to increase the ACE inhibitors apart from controlling the sugar. What can we do to decrease the albuminuria? So we know that high blood pressure is bad. We know that very low blood pressure is also bad. So we don't know what do you mean by the very low blood pressure. Very high blood pressure is 125 over 75 is bad. So we might have to control it beyond it. Very low is, some people have done it 110 over 60 as well, and they have proven. But how bad to decrease it, we don't know. Depends on the age and the comorbidity of the patient as well. If they are at the risk of falls, I might not risk it, but I might accept up until 110 over 60. But then I might add on the second agent. If the patient diabetic, whether he can tolerate low dose empagliflozin, that will come into place. The spironolactone, that will come into place. And a diltiazem, it is not a very effective short-acting diltiazem. They don't drastically bring down the blood pressure, but they might help in the proteinuria. But again, it depends on the trace of proteinuria, what is the degree of proteinuria, and how the progression has been in the past as well. So you better have to individualize depending on the age and the comorbidities. You might target for a lower level if the patient is tolerating it. If not, think about spironolactone, think about diltiazem as well. Then it's by Carrera. Thank you for the excellent lecture. What is the target to titrate proteinuria in clinic visits? More the better, more the better. We want to, 3 grams should become 1 gram, 1 gram should become 0.5 gram, 0.5 gram should become 0.3 gram. That's what is needed in a non-proliferative lesion. In a proliferative lesion or glomerulonephritis, we tend to target less than 0.5 grams to say that if it's persistently less than 0.5 grams of proteinuria, we generally call it the patient would be in remission. So that depends on the onset, what was the proteinuria. But it's the titration would depend, more the better. More the better is the answer. I think to an extent I've covered almost everything. All the questions.
Yeah. So we have another question posed to us on registration to the forum, sir.
Yep.
He asked, what are the alternatives we can use in a patient with proteinuria and high serum creatinine with worsening edema when the CCBs are started, calcium channel blockers are started?
Serum creatinine is elevated, is it?
Yes, the high serum creatinine and proteinuria with worsening edema. So he is asking for other alternative medications.
Yes, so I think so. Always look into whether you can give some ACE inhibitors, whether you can give some low dose ACE inhibitors, whether you can titrate it from a low dose and see whether the patient is tolerating it and there is no hyperkalemia effect. And also take some measure to make sure the potassium to come. The proteinuric effect, it's quite effective. It's a bit difficult. I might start up until EGFR 15. I will not start after beyond EGFR is 50, below 15. Up until EGFR is 15, I might put him on ACE inhibitor. The patient is tolerating as well. And also be careful. All of us have got a tendency that the serum creatinine is increasing in a proteinuric disease because invariably in CKD, serum creatinine is going to increase because of the chronic damage.
Yes, sir. And we have a follow-up question in the chat, sir. I think it was partially answered. Whether we can combine ACE inhibitors with calcium channel blockers in treatment.
Yeah, I will recommend so. There is no harm in it. Yes, like we got to reach the target of blood pressure control. But avoid the nifedipine might be better avoided if you have another option. But I would combine it.
All right, so thank you very much. So I would like to once again thank Dr. Brammah Thangarajah, the consultant nephrologist of the professorial unit of the Teaching Hospital, Jaffna, and the senior lecturer in the Department of Medicine of the Faculty of Medicine, University of Jaffna, for their elaborative and extensive lecture on the overview of glomerulonephritis. So kind reminder to the participants, you will be able to find a link in the chat box so you can finally give your feedback and answer the post-assessment questions in order to receive your e-certificate participation, which should be sent to you through email. So thank you once again, sir, for that extensive and elaborative session. And we hope that you would join hands with TREE and the GMOA for future collaborations on enhancing the knowledge of our junior professionals as well. So that ends up today's session on the CPD session, and hope you will have a wonderful day. Thank you.